So when we are thinking about neurobonding outside the box, so we are looking for procedure where the nervous tissue is at risk. And one of those procedure is any spine surgery or quad equina surgery or tethered cord surgery where the pudendal nerve is at risk. And pudendal nerve is typically monitored by recording from anal sphincter S2, S3, S4. But in some patients still can wake up with a neurogenic bladder. And the reason is the branches of the pudendal nerve going to the uh, anal sphincter are different than the branches supplying the bladder. So if we have not never monitored in the past the bladder and assume that if anal sphincter responses EMG and MEP are good, the patient will be okay. But now we have a specific electrode, a bladder electrode, which we can use and we can benefit the patient. So let's discuss the bladder monitoring in this surgical procedure. There are two things you can do that. You can do trigger motor evoked potential. You can do trigger EMG, and we are also testing the bulbocavernous reflex using this one, which I have not published yet. But MEP and trigger EMG, we have published the first papers utilizing the urethral electrode and recording from external urinary sphincter motor evoked potential or USMEP. So as we know, the multimodality neuromonitoring is routinely performed during spine cases, conus cases, quad equina cases, nerve tumors, and tethered cord cases, but bladder is not part of those. Ball and bladder function is at risk in these procedures because of that level. And we only monitor EMG and MEP from external anal sphincter muscle. And we have a very narrow view of pelvic floor function providing by only the external anal sphincter muscle. So when we add US MEP or unisphincter MEP, we can give more benefit and monitor urinary sphincter by using the urethral catheter electrode. So pudendal nerve, the different is very complex area and have multiple nerves which are supplying. The pudendal nerve is the um, originate from S2, S3, S4, and it controls urethral sphincter. The pelvic nerve is control the bladder contraction and is a parasympathetic nerve, and sympathetic nerve is the hypogastric nerve and which causes control bladder relaxation. So these are all at risk in the surgical procedure. So clinical consequences of abnormal urine storage and voiding after severe upper motor neuron or suprasacral spinal cord injury. And if the patient has normal storage, spinal cord injury, overactive C fiber efferent, and neurogenic deterrence overactivity, which result in urine leakage, decreased storage capacity, decreased compliance, and decreased intravesicular. If the patient has spinal cord injury, can have simultaneous detrusor and sphincter contraction, which result in detrusor sphincter dyssynergia with high residual volume, urine retention, bladder hypertrophy, and increased intravesicular pressure. And all of this will result in recurrent UTI. So these patients will have recurrent urinary tract infection. They will have multiple drug resistance develop over the year. They will have upper UTI and deterioration, and they also get reduced quality of life and lifespan. So we are trying to minimize that. So lower unit tract intervention and neurotransmitters we can do by, you can see the pelvic nerve is parasympathetic, secreting acetylcholine and acting on the muscarinic receptors. Hypogastric nerve is sympathetic at a beta R receptors, and pudendal nerve is nicotinic receptors. So our paper, which was the first paper published, demonstrating the capability of recording motor evoked potential from urethral sphincter muscles during spine surgery. So we did a retrospective analysis of neuromonitoring, and this data was collected in 5 medical centers in 3 different countries. The patient had 8 males and 7 females, and the range from 8 months to 66-year-old. The average age was 38.9 years in this study. The urethral sphincter electrode were used to record US MEPs in 15 patients, diagnosed with nine patients were diagnosed with intradural tumor, 4 were tether cord syndrome, and 2 spinal stenosis. 6 of these patients, they had intradural tumors of the conus, 3 with the lateral spinal cord tumors, and 4 with tether cord syndrome, and 2 with severe stenosis. So we monitor. So we did multimodality monitoring. So we had upper and lower SSCP, upper and lower MEP, EMG, also from external anal sphincter and urethral sphincter muscles, and lower extremity bilaterally. So the catheter, there's a specific catheter which has electrode attached, Foley catheter, we use for recording MEP and EMG, and we did train of 4. And we use the appropriate catheter size depending on the patient age, sex, urethral size, and weight. So you have to select the size of the catheter you are using, and it is the catheter are typically are labeled in French size, which is the symbol is FR, and which tells about the size of the urethral catheter electrode. And every unit, one FR is equal to 0.33 millimeter in diameter. So 18 French indicate a diameter of 6 millimeter. So urethral sphincter electrode options, we have 8 French or 10 French for clip. We also have 6 French, which is now available, but it's only monopolar because of very, very tiny, and it's used on less than 8 month old patient, less than 8 month. Then you can do sometime for, you may be able to do 8 French, but 6 is the ideal for that. The adult size are 4, 16, and 18 French. Here we can see the electrode with embedded bipolar electrode on the catheter, and when you place in the middle picture, we can see the balloon is inflated. The electrode is in contact with the whole external urinary sphincter. So male is the urethra is longer as compared to female, so this is a longer electrode, so which is appropriate for both male and female. You don't need to. And then on the right side we can see the catheter and urinary catheter, and it has 2 electrodes coming out, and these are 2 active end references, and we can plug into our main head box and do the recording. So let's see the data. So we have 15 patients, and with all patient, and you can see the anal sphincter recording, which is plus means good, and plus is better than that, and 3 plus are best. So the urinary sphincter recording in all these patients has much better responses than anal sphincter responses. So this is the patient number 1. You can see urethral electrode has a good MEP compared to the left and right anal sphincter muscle. Another patient number 2, you can see left foot and right foot, they are good, but left anal sphincter, right anal sphincter, they are not as good as the urethral sphincter. So urethral sphincter have more stable and high amplitude responses than the anal sphincter response. Patient number 7, outside patient, we have MEP absent in urethral electrode for beginning, but after the tumor was removed or decompression done, so we start getting MEP from urethral electrode, and the left foot and right anal sphincter, they are stable throughout the case. From the patient number 9, so we just the example, so we have stable foot muscle, anal sphincter, and urinary sphincter. So again, we can see the EUS or external urinary sphincter responses. They are much better recorded compared to the anal sphincter muscle, but they are both giving different information, so we cannot choose one or two. Should be monitoring both of them for these spine procedures, tether cord procedures, and cardiac tumor procedure. So 14 patient had good recordable MEP from urinary sphincter MEP. 93% of patient had good signal, and 7% has not recordable, and that was at the baseline, and there was no recordable MEP at the baseline. It stayed like that. Participation from the anal sphincter muscle was not recordable in 1 patient, and then it was poor in 2 patients, it was reliable in 2 patients, and one not recorded in 1 patient. The amplitude of MEP was higher for all these patients for urinary sphincter as compared to the anal sphincter electrode. So we have one patient with absent at the baseline, and then we have 14 patients with present. This is the same. So in this small study, we were able to require motor evoked potential successfully from the urinary sphincter in 93% patient. And it should be and urinary sphincter MEP should be done when in all the surgeries where it puts the pudendal nerve at risk. So that was true MEP, but we also did trigger EMG. So you can, because you had more recording from that, so you can recording from, and we published this paper. This also our first paper published about trigger EMG recording for urinary sphincter muscle. And we had 10 patients, and they were equally divided with gender, 5 male, 5 female, and age distribution here. And you can see trigger EMG, this red arrow, and it was a very focal stimulation, and you're recording from a sphincter's muscle. Here is a stack of the responses, and you can see responses from anal sphincter and urinary sphincter recordable. So we successfully recorded trigger EMG in all 10 patients, so we have 100% success. Only one patient presented preoperative with bladder incontinence. Only one patient had preoperative and bladder incontinence, urgency and frequency. And immediately after post-surgery, the patient frequency and urgency was improved, and the bladder function normalized within the 2 weeks of having the tumor removed. None of these patients have any deficit post-operatively. So again, in this small study, we have 100% of patient has recordable trigger EMG from urinary sphincter, and trigger EMG from urinary sphincter should be done for all the cases in pelvic floor function is at risk. But to do a better study, so I encourage everyone to do a more bigger study, to do patient with 100 patient or 1,000 patient, and you see how it goes. Thank you.